Welcome to the webinar sponsored by American College of Physicians, Indian chapter. I thank Dr. Muruganathan for this wonderful opportunity. I am Dr. Chenniappan, Senior Cardiologist in Trichy, also Professor Emeritus, Tamil Nadu Dr.M. University, Chennai. My topic today is going to be Clinical Cardiology, a Forgotten Art. In the presence of increasing gadgets and techniques, we are likely to forget our clinical cardiology, and that is the main focus of this topic. Dr. Venkatesan's posting go to the extent of saying that the clinical cardiology is facing a death sentence. So as a disclaimer, I want to tell that don't expect hazard ratios, Kaplan-Meier curves, p-values in this presentation. There will be no bar diagrams. There will be no complicated name trails. Neither you will have a guideline and journal references. So most of this patient scenarios in the CME are purely experience based, and we are going to look at these patient scenarios through the eyes of Dr. Good and Bad, so that we'll know what to be done, what should not be done. All these patient scenarios are basically the scenarios in which the clinical examination helped us to make a diagnosis, overcoming the available investigations. So first we see a patient with left ventricular hypertrophy. This 45-year-old CEO of an IT company comes for a mastical checkup. He is completely asymptomatic. His clinical examination is unremarkable. His clinic BP is 130/80, and ECG and echo shows left ventricular hypertrophy. The blood studies did not show any abnormalities. So Dr. Bad thinks it is unexplained LVH in the absence of aortic stenosis and hypertension. It is likely to be hypertrophic cardiomyopathy. So he warns him about the sudden death and further complications, advised Holter and cardiac MRI to plan further management. Whereas Dr. Good clinically examined the patient to find the clinical LVH. He also looks at the fundus to identify grade 2 hypertensive retinopathy. Then he orders 24 hours ambulatory BP monitoring, although his clinic BP is normal. This is his 24 hours ambulatory BP monitoring, which showed that the BP goes up to 180 when he is chairing a session. Then he is giving a lecture and his BP goes up to 160. And once again, the next lecture, the BP goes up to 180. And for the third lecture, the BP goes up to 160. In between, he comes to the clinic in his institution and check the BP with the doctor there, where the BP is absolutely normal of 130/80. Then he goes home and has dinner with his wife probably. Once again, the BP goes up. And absolutely, there is a significant drop in the BP in the night. So here you can see the BP is varying so much on 24 hours basis. Still, we plan our management on a single BP reading in the clinic. So here, this type of hypertension, where the patient has hypertension in the working place and in the house, whereas normal blood pressure in the clinic is called masked hypertension. This masked hypertension is because of the enormous stress the patient undergoes in his working place, in or her working place, or whenever the patient enters the home and sees the major risk factor inside the home, his or her blood pressure goes up, whereas the clinic blood pressure is absolutely normal. So the masked hypertension is about 10% of general population. It is present in 30% of treated hypertensive patients. It is called masked effect of the treated hypertensives. The masked hypertension is likely to be higher in patients with diabetes and chronic kidney disease. And 1 out of 3 treated hypertensive patients will have masked hypertension. Almost 30% of patients, you will think the BP is controlled, but he will have high blood pressure in working place or in his house. The prognosis of masked hypertension is the same as the sustained hypertension. It is more dangerous than sustained hypertension because many times it is not diagnosed or it is not suspected, because every time the patient comes to the clinic, the blood pressure is normal. So, based on ambulatory BP monitoring and home BP monitoring, we have several subsets of hypertension today. So, we have to look at the BP at the clinic and also the target organ disease, also the BP at home or working place. A pure normotensive is the one who has got normal BP at clinic, normal BP at home, and no target organ disease. Whereas white coat hypertension is the one who has got high BP in clinic, normal BP at home, and he will also may not have a target organ disease. Whereas a masked hypertension patient will have normal BP in clinic, high BP in working place or in his house, he will have a target organ disease. This is the one pointer towards masked hypertension is unexplained target organ disease like LVH, hypertensive retinopathy, albuminuria, like that. In the presence of a normal clinic blood pressure, you have to suspect masked hypertension. True hypertension is the one where clinic BP is high, home and working BP is high, and target organ disease is present. So that's why now we realize the treatment of hypertension is not going to be depending upon the clinic blood pressure alone. We must have some idea of blood pressure outside the clinic for a proper management of a patient with hypertension. So the lesson we learned from this patient is that unexplained LVH is always not hypertrophic cardiomyopathy. Rule out masked hypertension before you diagnose hypertrophic cardiomyopathy. Masked hypertension is most often not diagnosed and treated, that's why it is more dangerous. Suspect masked hypertension whenever there is a target organ disease in the presence of normal clinic BP. Advise ambulatory BP monitoring or home BP monitoring for planning and for planning treatment, as well as for the diagnosis, as well as for the follow-up. Next, we come to a patient who has got chest pain. This 55-year-old male diabetic was admitted for acute interval infarction and thrombolized 2 days ago and on routine drugs after thrombolysis. So the patient has chest pain today, and the ECG repeated today showed persistent ST elevation anterior-chest leads as well as some fresh ST elevation in inferior leads. So this is the patient's ECG. You can see that there is signs of evolved Q waves, evolved infarction, in addition to a persistent elevated ST segment in anterior leads and higher lateral leads, and there is also elevation in L2, L3 and AVF. So with this clinical scenario and ECG, Dr. Bad thinks it is a reinfarction of anterior wall as well as fresh inferior wall infarction. So he thinks there is a fresh occlusion of LAD as well as a independent occlusion of RCA. So he plans an immediate coronary angiogram for a revascularization. Whereas Dr. Good goes into history, the patient clearly says that the pain today he has is completely different from the pain he had on the first day when he was admitted for acute myocardial infarction. This pain is pricking, more related to swallowing and the posture and deep inspiration. And when the Dr. Good auscultated, there was a triphasic pericardial rub, and now we have a clear idea that this persistent or new ST elevation is due to the acute pericarditis of acute myocardial infarction and not due to the reocclusion of LAD or a fresh occlusion of RCA. So the plan of treatment is going to be to stop heparin, increase aspirin, reassurance of the patient that there is no fresh changes, and ultimately the patient becomes better. So the lesson we learned from this patient of chest pain is that the chest pain on second day or third day of STEMI always rule out acute pericarditis. One of the important causes of chest pain on second day or third day, the serial auscultation is necessary because the pericardial rub is most often transient. First elevation may not occur only in infarcted leads, but also in other leads because the pericarditis is diffuse. The management is completely different because in ischemia, you have to continue heparin or step up other anticoagulants, whereas if there is pericarditis, heparin and anticoagulants should be stopped and the aspirin has to be increased. Then we see another patient with acute severe chest pain or arm pain. This patient comes with intermittent left arm pain for 3 hours. He is a known diabetic and hypertensive. He is hemodynamically stable. ECG taken immediately showed ST elevation in anterior leads. So this is his ECG, which shows a significant ST elevation in anteroseptal as well as the anterolateral leads. So Dr. Bhatt thinks it is acute interval infarction. Because there is an ST elevation in V1, he thinks it's a proximal LAD disease. Because of its proximal LAD disease with interval infarction, he plans immediate coronary angiogram and primary PCI for the LAD. Whereas Dr. Good goes into history. He found that the left arm pain radiates from the back of the neck related to movements of the neck, and there is a local tenderness. He compares with the old ECGs with today's ECG. All the previous ECGs look the same. Patient has persistent ST elevation is because of the persistent elevation in this patient is probably because of left ventricular aneurysm. Echo confirms the diagnosis of left ventricular aneurysm. He gives simple symptomatic treatment with simple analgesics for the left arm pain, and patient becomes better rather than going in for an immediate angiogram. So this is a ECG taken in 2008, which shows the same similar persistent ST elevation few years ago. So these are the causes of persistent ST elevation after acute myocardial infarction. In acute phase, it may be due to the failure of thrombolysis or reocclusion. It can be due to significant left ventricular dyskinesia, associated pericarditis, a transient ST elevation in AVL, along with electromechanical dissociation with sudden collapse may tell us that the patient has got a free valve rupture. In chronic phase, the persistent ST elevation can be due to left ventricular aneurysm, severe dyskinesia, associated left bund branch block, and metastatic tumors inside the myocardium can produce ST elevation, but there will not be any pathological Q waves. So the lesson we learned from this patient is, in any known coronary heart disease patient, it is always a good practice to compare the fresh and old ECGs before planning the treatment. Please remember that any known coronary heart disease patient can also have a non-cardiac chest pain, because we have a mindset to believe any pain in a coronary heart disease patient is likely to come from coronary artery disease. Careful history regarding the nature of the chest pain is crucial, and comparing the previous ECGs is also crucial. Now we come to patient number 4. This is a patient who is 60-year-old male, admitted with acute severe chest and back pain, and severe pain, is rolling with pain. It's a known case of high blood pressure on irregular treatment. The pulse is 90 per minute, BP is 160/100. ECG shows ST elevation anterior chest leads. There is no history of previous myocardial infarction. Because the first medical contact to primary PCI time is more than 120 minutes, and there is no contraindication to thrombolysis. So this is his ECG, which has got, a patient has got severe chest and back pain. Pressure is around 160/100 or 150/100, and you can see the elevation in anterior chest leads the patient is having. So with this clinical scenario on ECG, Dr. Bhatt thinks it is acute ST elevation MI. It is in LAD territory. The ST elevation is in LAD territory. So because the FMC to the PCI time is more than 120 minutes and patient is hemodynamically stable, he plans an immediate thrombolysis. Whereas Dr. Good feels that the pain is maximal at onset and the character of the pain is tearing. The pain is radiating to the back and also radiates below the umbilicus into the legs. The careful clinical examination revealed inequality of pulses. There is significant aortic regurgitation. So with this clinical findings and history, Dr. Good does immediate echo and transesophageal echo as well as the CT scan to diagnose an acute dissection of aorta and plans appropriate management. So the lesson we learnt from this patient is, in all acute severe chest pain patients, always note the following for not missing a dissection. It is a good practice to look into these features before you thrombolize. If it is a predominant back pain, tearing in quality, when the pain is maximal at onset, whereas ischemic pain becomes severe over the course of minutes, whereas the acute dissection pain is maximum at onset. Inequality of pulses, presence of aortic regurgitation, the pain is radiating into the legs below the umbilicus. As you know, the ischemic pain may not go below the umbilicus. So with this clinical findings and history, one must suspect dissection before thrombolysis, because thrombolysis is contraindicated in dissection. So now we see a patient with edema. This 35-year-old patient is admitted with bilateral pitting edema of legs, ascites and elevated jugular venous pressure. Pulse rate is 110 per minute, BP is 90/60. Heart sounds are reduced intensity. There is a suggestion of a third heart sound. The lungs are clear. Dr. Bad thinks it is a congestive heart failure, systemic venous congestion, so it is likely to be a right heart failure. So he plans intravenous diuretics, fluid and salt restriction, a routine treatment like digoxin, and because the BP is low, he plans a dopamine and then plan an echo. Whereas Dr. Good finds out that the ascites came first. The careful clinical examination revealed there was a pulsus paradoxus. JVP was getting elevated more in inspiration. The negative waves are prominent rather than the positive waves like V waves. The diastolic sound, which looked like third heart sounds, is probably pericardial knock. There were no murmurs. The heart sounds were muffled. So with this clinical examination findings, he does an immediate echo to find a massive pericardial effusion with tamponade. The aspiration and subsequent workup for the etiology and the treatment is planned. So whenever the patient comes to you with a systemic venous congestion, it could be a right heart failure or a pericardial disease. There are a lot of clinical pointers to differentiate them. In right heart failure, the JVP is elevated with positive waves like V wave. Whereas in pericardial disease, the JVP is elevated, especially it becomes more elevated during inspiration with predominant negative waves like X and Y descents. There is no significant change in respiration in right heart failure, whereas the JVP will rise in inspiration in pericardial disease. Lungs may show crepitations in right heart failure. The lungs are clear in pericardial disease. Pulse volume may be normal or low. There is no change of volume in inspiration, whereas there may be a typical paradoxical pulse where there is reduction in volume of pulse during inspiration, which is confirmed by blood pressure. Most often, murmur of tricuspid regurgitation may be present, or pulmonary regurgitation may be present in right heart failure. Then pericardial disease, there may not be any murmurs. The rub may be present sometimes. In right heart failure, the edema comes first, whereas in pericardial disease, ascites comes first, because in pericardial disease, the pressure over the hepatic vein is much more than the pressure over the inferior vena cava. Because of that, the ascites comes first in pericardial disease, which is called ascites precox. The history of where edema started will give a clue of the etiology of edema. If the edema ascends from the foot to face, it likely to be cardiac. If the edema descends from face to foot, it is likely to be nephrologic causes. If the edema is in the middle, it could be pericardial disease or hepatic disorder like cirrhosis of liver. So the lesson we learned from this patient is whenever a patient comes to you with systemic venous congestion, it is always good practice to rule out a pericardial disease which exactly mimics right heart failure. Examination of arterial and venous pulse will give valuable clues apart from history. Why this is important? What is the practical implication? Treatment of heart failure like diuretics, digoxin, AC inhibitor, positive inotropic agents may worsen pericardial disease by reducing the preload, afterload, and by increasing the heart rate. That's why it is very, very important to differentiate a pericardial disease from right heart failure whenever the patient presents with systemic venous congestion of elevated JVP, ascites, enlarged liver, and edema. Then we see a patient with dyspnea. This patient, who is a known case of severe left ventricular dysfunction, admitted to our class 4 heart failure, in spite of optimal and maximal guideline-based therapy of heart failure, the patient continued to be symptomatic. The pulse is 102 per minute, BP is 170, third heart sound is present. The bilateral crepitations were heard, more on the left side. Respiratory rate is 30 per minute, SaO2 is 90%. ECG showed sinus tachycardia, left bundle branch block, and left atrial enlargement. Dr. Bad diagnoses this as a refractory heart failure because of the persistent symptoms, and he increases the diuretics as well as plans positive inotropic agents. Because the patient has got left bundle branch block and a poor LV function, he plans a cardiac resynchronization therapy as soon as possible. Whereas Dr. Good, after a good clinical examination, finds that there is significant reduction of breath sounds in the whole of the right chest. On percussion, there was dullness over the right chest. X-ray chest revealed large right pleural effusion, and the dyspnea, the cause of dyspnea is right pleural effusion rather than exacerbation of heart failure. The aspiration, analysis of pericardial fluid and treatment of the cause, the patient with this treatment, the patient becomes completely normal. So this is X-ray of the patient which shows a significant right side effusion here. So this is the cause of dyspnea rather than left heart failure. So just like we said in chest pain, any patient with a severe LV dysfunction or a patient with a known heart disease or a heart failure, dyspnea is not always due to either left ventricular dysfunction or heart failure. There are a lot of causes of dyspnea other than LV dysfunction. The most important cause is pleural effusion. Many times the right heart failure will produce significant pleural effusion, which may be the cause of the dyspnea. So mechanical removal of fluid only will relieve dyspnea of this patient rather than pumping in the higher doses of diuretics. The patient have an associated bronchial asthma. So sometimes the wheezing is so high, you may have to use steroids to relieve the dyspnea. And the patient may have a cardiorenal syndrome, especially type 1 or type 2, where the patient may have an associated acidosis, where there is a hyperventilation which will mimic dyspnea. So any patient with heart failure is a potential candidate for a pulmonary embolism, which must always think of pulmonary embolism in all cases of acute dyspnea in a patient with heart failure. And the simple anemia due to various causes, including AC inhibitor therapy, which can produce anemia, can produce dyspnea. Associated respiratory infection and anxiety also will, deep sighing in anxiety also will mimic dyspnea in patients with left ventricular dysfunction. So the lesson we learned from this patient number 6 is that dyspnea in a known LVD and heart failure patients, once again, it may not be due to cardiac cause. We have to keep looking for the other causes of dyspnea other than the heart, because the management is completely different when you find out a non-cardiac cause of dyspnea and treat it, rather than thinking about the cardiac cause and go on treating cardiac cause may not relieve the dyspnea in these patients. Patient number 7 is a female of 60 years, known diabetes and hypertensive and amlodipine. She complains of dyspnea of class 3, no PND or orthopnea. BP is 160/100. There is no signs of systemic venous congestion. A clinical auscultation did not reveal a murmur or a third heart sound. The chest is clear. ECG showed left ventricular hypertrophy. Echo showed left ventricular hypertrophy, left atrial enlargement. There was grade 1 diastolic dysfunction with ejection fraction of 58%. There is no valvular lesion or pulmonary hypertension. There is no significant abnormalities in blood chemistry. The X-ray chest, the CT ratio was normal. Dr. Bhatt thought there is no evidence of heart failure today because there is no third heart sound, there is no cardiomegaly, JVP was 0, and there is no edema. Ejection fraction is around 58 to 68%. There was grade 1 diastolic dysfunction, which he thinks it's age related. X-ray showed no cardiomegaly. So because of these reasons, he thinks that the dyspnea is non-cardiac, and add beta blockers to control the blood pressure, and refers the patient to a psychiatrist for the evaluation of the functional causes of dyspnea. Whereas the Dr. Good does a skillful clinical auscultation which revealed a fourth heart sound, and looking at the ECG carefully, he picks up a deep terminal negative P force in V1, which is likely to be left atrial abnormality. X-ray, once again careful examination showed a redistribution of pulmonary veins. The upper lobar veins are prominent, which may indicate early pulmonary venous hypertension. In addition to grade 1 diastolic dysfunction, he looks at a very important tissue tablet parameter of E/E ratio, which is more than 50. That is, it is 20, indicating significant increase in left atrial pressure. So, patient having dyspnea, an elderly lady with hypertension and diabetes, with left ventricular hypertrophy and left atrial enlargement, with abnormal diastolic parameters and signs of increased left atrial pressure, he makes the diagnosis of heart failure with a preserved ejection fraction as the cause of dyspnea, and a strict control of blood pressure with additional drugs like angiotensin inhibitors, small dose of diuretics, and the controlling the risk factors. With all this treatment, the patient becomes better. So this is the patient's ECG. So whenever you have a hypertension which shows a left ventricular hypertrophy with pressure overload in the form of secondary ST changes, and also not only in the first ECG, through the course of the patient's treatment, through the course of patient's visit to you, you have to always concentrate on the P negative force in V1. The P negative force is becoming deeper and deeper over the course of months and years, is an indication that the patient is developing a significant increase in left-sided pressure, especially the left atrial pressure. It can be in the presence of systolic dysfunction, or it can be also due to presence of normal systolic function or a preserved systolic function with significant diastolic dysfunction of elevated LA pressure, which is shown by the tissue Doppler parameter of E/E ratio. So this is the deep negative P terminal force in V1, the most important finding in any patient with hypertension and LVH. So now our concept of ejection fraction is changing, because previously we thought ejection fraction is synonymous with the systolic function of the heart. So whenever the ejection fraction was normal, we thought the systolic function was normal. Now we understand the heart is not contracting and relaxing in the horizontal manner. It is more often contracting and relaxing as a twisting and untwisting mechanism. During the twisting mechanism, the blood is pumped out. During the untwisting mechanism, the blood is coming into the chambers. So for this twisting and untwisting action, the most important muscles are the longitudinal muscles, which constitute about 70% of the heart muscle. When you do an ejection fraction, it gives you an idea about the circumferential fibers and not about the longitudinal fibers. So that's why we can still have features of heart failure in the presence of preserved ejection fraction because of the involvement of longitudinal fibers rather than the circumferential fibers. So the other reason for the dyspnea or features of heart failure in the presence of normal ejection fraction is diastolic dysfunction. So heart failure with the preserved ejection fraction is not only a pure diastolic dysfunction, but also occult systolic abnormality of the longitudinal fibers. So when we do a routine ejection fraction through the M mode or 2D, we are looking at circumferential fibers. Whenever we do a tissue Doppler, that we are looking at the longitudinal fibers. The systolic function as well as the diastolic relaxation function of the longitudinal fibers can be beautifully brought out by the tissue Doppler parameters. So heart failure with the preserved ejection fraction is a situation where your circumferential fibers are working well, but the longitudinal fibers are not working. So that's why you have a normal EF, ejection fraction, but the tissue Doppler parameters such as the S wave, E prime and A prime are becoming abnormal because there is a longitudinal function abnormality. The most important parameter we look at the tissue Doppler is called the mitral valvular E wave divided by the mitral annulus movement in diastole, early diastole of E prime. So mitral flow pattern, mitral flow E divided by the tissue Doppler E prime gives us an idea about the rise in left atrial pressure, because whenever the left atrial pressure is raised, the E wave in the mitral Doppler is going to be increased. Because of the poor relaxation, the E prime is going to come down. So E is increasing and E prime is coming down. Naturally, your ratio is going to become more. So in any long-standing hypertension, diabetes, elderly female coming to you with dyspnea, although the patient has got an echo report showing a normal ejection fraction, please don't think this dyspnea is non-cardiac. Because heart failure with the preserved ejection fraction is increasing and it is going to be the future heart failure. The clinical examination is very important. Detection of fourth heart sound with a significant left ventricular hypertrophy. In ECG also, the deep terminal P wave force in V1 with LVH, and in echo, the abnormal tissue Doppler parameters like abnormal S wave, abnormal E bar E prime will give a clue that this dyspnea is definitely cardiac and it is due to hypertension with the preserved ejection fraction. Whenever the E bar E prime is more than 15, even in grade 1 diastolic dysfunction, which we always think it is not a very big deal and it is likely to be age related, even in grade 1 diastolic dysfunction, if the E bar E prime is going to be more than 15, it indicates that this patient has got high left atrial pressure, and these patients are the ones who suddenly land up with acute pulmonary edema, which most often we call them as the flash pulmonary edema. So the lesson we learned from the patient number 7 is dyspnea with normal ejection fraction is not always non-cardiac. Then we look at a patient with syncope. This patient, who is a known case of coronary heart disease and diabetes mellitus, who had an acute coronary syndrome 2 months ago on routine treatment of post-ACS like nitrates, dual antiplatelet statins, beta blockers and ACE inhibitors, develops through episodes of syncope when he got up in the morning and went to the toilet. So on arrival into ED, his examination pulse is 66 per minute, BP is 100/70. There were no clinical findings in the cardiovascular system and respiratory system. The ECG showed right bundle branch block, left anterofascicular block, and anteroval myocardial infarction. So Dr. Bat thinks that because of this bifascicular block with syncope, this is likely to be a transient Stokes alarm attacks due to complete heart block, and plans immediate temporary pacemaker and then a permanent pacemaker therapy in this patient. Whereas Dr. Good compares the present day ECG with the old ECG and sees that RBB and LAFB were there even in the previous ECGs. The important interval here is the PR interval. The PR interval was normal in both ECGs, excluding a trifascicular block and subsequent complete heart block. Then he checks up for the postural blood pressure. There was a significant postural hypotension. Then he asks history of melena. The patient says yes for the last 2 days. He sends the stool for occult blood examination from the rectal examination which came as positive. The routine investigation like hemoglobin, PCV, urea and creatinine are all suggestive of an upper GI bleed. He stops dual antiplatelet drugs, give patch transfusion, upper GI scopy was done subsequently, and patient became better. So once again, just like we said about chest pain and dyspnea, syncope also in a known cardiac patient look beyond heart. The most important reason in a cardiac patient having syncope is postural hypotension. It can be due to drugs, upper GI bleed as in our patient, autonomic nervous system disorders like Parkinsonism, situations like fever and dehydration, or in summer, the patient may go for significant postural hypotension and have a syncope. There may be situations in syncope, especially in elderly, mixed-urin syncope and cough syncope. It could be also a vasovagal syncope. Sometimes the patient tends to take a sublingual nitrate for all his complaints, and some mild chest pain or giddiness, the patient takes a sublingual nitrate, and patient may have significant hypotension and may have a syncope. Of course, we should not forget the other causes of LOC like hypoglycemia and seizures. Many conditions mimicking syncope also to be excluded. The drop attack, severe vertigo, dizziness. In all these conditions, the patient will not lose consciousness. Whereas syncope, there is a transient loss of consciousness with loss of postural tone from which the patient recovers spontaneously. So the lesson we learned from this patient number 8 is that once again syncope in patients with coronary heart disease or a cardiac disease patient, especially on a dual antiplatelet drugs, always rule out occult upper GI bleed. Check for postural hypotension and occult gastric bleed, history and rectal examination. History of melena may not be forthcoming in many of the patients. Syncope in cardiac patient is not always due to cardiac lesion. A good history, clinical examination will find out or will tell us that the syncope is because of many other reasons, and the treatment of which will actually bring the patient to normalcy. Then we look at a patient with a palpitation, 2 patients with palpitation now. So 45-year-old known coronary heart disease patient walks into outpatient with history of palpitation. He has stable hemodynamics. The ECG is taken and shown. This is his ECG, which showed wide QRS complex regular tachycardia with a right bundle branch block pattern, and there is a left axis deviation. So patient is absolutely stable and he is around 45 years. So from this ECG, the clinical examination Dr. Bad thinks because the patient is hemodynamically stable and the ECG is showing a right bundle branch block and it is relatively a narrow QRS, and because he walks into his office with a very stable hemodynamics, he diagnosed this as supraventricular tachycardia with a right bundle branch block and orders intravenous adenosine. Whereas Dr. Good is able to get the history of previous myocardial infarction from this patient, and careful examination of the neck vein shows intermittent Cannon waves, and the auscultation revealed varying intensity of first heart sound, the two important clinical signs of atrioventricular dissociation. Then carefully sees the ECG for the demonstration of intermittently occurring P waves in between the QRS complexes, and he finds that there is significant P waves in presence of the QRS and in between the QRS, and confirms atrioventricular dissociation. So diagnose this rhythm abnormality as ventricular tachycardia and orders intravenous lidocaine, from which the normal sinus rhythm is restored. So although in any white QRS complex tachycardia we immediately look at the ECG, there are a lot of clinical clues to diagnose whether it is an SVT with aberrancy or ventricular tachycardia. An elderly patient is likely to have VT. An old MI patient, 90% of times, a white QRS tachycardia is likely to be VT. Any structural heart disease like cardiomyopathy, especially hypertrophic cardiomyopathy or a dilated cardiomyopathy patient come to you with a white QRS tachycardia, it is likely to be VT. When the patient has got history of sudden death, or he is taking drugs which will prolong QT interval, he has got potassium and magnesium abnormalities, and there are two clinical signs of AV dissociation in the form of intermittent occurring Cannon waves and varying intensity of first heart sound. So whenever these clinical signs and the history is present, most often the white QRS complex tachycardia is VT. Whereas a patient with SVT is much younger, most often will have normal hearts. The previous sinus rhythm ECGs may show a pre-excitation pathway or a bundle branch block, and in the neck, especially during an atrioventricular re-entry tachycardia, atrioventricular nodal re-entry tachycardia, because the atrium and ventricles are contracting simultaneously, you will have regularly occurring Cannon waves, which is called the frog sign. So these clinical pointers before the ECG itself will give a clue whether your white QRS complex tachycardia is VT or SVT with aberrancy. Please remember that the hemodynamic stability or instability does not differentiate VT from SVT, by which I mean an VT patient can walk into your office, SVT patient may come with shock. So this is where we have shown you the intermittently occurring P waves during the course of this white QRS complex tachycardia. We can see the P wave is occurring just in front of the QRS here, after the T wave here, just in front of the QRS here, and it is once again in the T wave. So you can nicely see intermittently occurring the P waves, which demonstrate that this is an atrial ventricular dissociation, which is a characteristic, which is an important sign to diagnose a ventricular tachycardia. So this patient told us that in any white QRS complex tachycardia, in addition to ECG finding, concentrate on history and clinical signs, intensity of first heart sounds. It will give us an idea about whether this white QRS complex tachycardia will be VT or SVT. Why this is important is any drug which is given for SVT, like digoxin, verapamil, adenosine, or diltiazem, all are dangerous to VT. So that's why the diagnosis, the correct diagnosis at the correct time is very crucial. So now we go to the patient number 10. This is a 70-year-old lady, comes with intermittent palpitation and giddiness. ECG is taken and shown, and this is the ECG of this patient, which showed the polymorphic QRS complexes in multiple leads, and the patient has intermittent palpitations. So with this electrocardiogram, the Dr. Bad thinks this is a torsade pointus and polymorphic ventricular tachycardia and orders the patient to have IV magnesium, or if the patient is hemodynamically stable or unstable, he wants to give a DC shock to convert this to sinus rhythm. And subsequently, he plans electrophysiologic studies and then an ICD. Whereas Dr. Good carefully sees the ECG. In computer ECG, the leads are simultaneously recorded. That's a very important point to remember. One can't have a torsade pointus in the lead 1 and 3 and have a completely normal sinus rhythm in lead 2. Then sees the patient clinically. The pulse is well felt during the so-called episodes of torsade pointus. He then identifies the tremors in the hands. Then he makes the diagnosis of somatic tremor artifact due to Parkinson tremor, which produces ECG changes like torsade pointus. So this is the ECG of this patient. As you can see, this torsade pointus like the QRS complexes are in L1 and in L3. Please remember L1, L2, L3 are simultaneously recorded. So you cannot have torsade in L1 and L3 and completely normal sinus rhythm in L2. And what is very important is to see the normally occurring QRS complexes inside this abnormal waves, which will give you a clue that this is an artifact rather than a classical torsade. And because the patient had a tremor in L1 and patient had predominant tremor in AVL and also artifact, these artifacts are in L1, AVL and L3, all these three leads utilize the left upper limb. So in these three leads, this artifact is very obvious. So likely that this patient is having not only a Parkinson tremor, but the predominant Parkinson tremor is in the left hand. So there are a lot of clinical clues in arrhythmias because we have a mindset to look at the ECG immediately. But please remember to do some clinical examination, which will give you a valuable clue when the ECG is not helping you. The arterial pulse will confirm an arrhythmia as well as the hemodynamic status. The venous pulse will give a clue to the type of arrhythmia, as I told, the intermittently occurring Cannon wave or regularly occurring Cannon waves and so on. Venous pulse is the only way to say that clinically patient is in sinus rhythm. A and V waves are seen sequentially with a normal rate, then only we can say clinically the patient is in sinus rhythm. The Cannon waves are intermittently occurring huge waves. If the intermittent Cannon waves are occurring, look at the heart rate. If it is occurring in the presence of bradycardia, it is likely to be a complete heart block. If it is occurring in the presence of a normal heart rate, it can be a pacer rhythm, especially a pacemaker like a single chamber pacemaker like VVI pacemaker. When the patient has got intermittent Cannon wave in the presence of tachycardia, it is likely to be a ventricular tachycardia. If the patient is going to have a regular Cannon waves, if the heart rate is normal or low, it could be a junctional rhythm. If the heart rate is faster, it is likely to be AV nodal re-entry tachycardia, which is called as frog sign. The auscultation, the most important auscultation finding is varying intensity of first heart sound. If the heart rate is irregular, it is atrial fibrillation. If the heart rate is slow, it is complete heart block. If the heart rate is fast, it is likely to be ventricular tachycardia. So lesson number 10 is that not all palpitations are arrhythmias and not all arrhythmias palpitate. Please try to treat the patient and not the monitor or the electrocardiogram. So the cardiology today is overwhelmed by high-tech gadgets, techniques, and also the investigations. So with all this, the main suffering portion of cardiology today is the clinical cardiology. So almost we forgot about the clinical examination of the heart, how much information this simple history taking, a good clinical examination of JVP, arterial pulse, auscultation of the heart will give us. So the takeaways from my presentations will be, even in this high-tech era, the careful clinical examination still stands tall. We have to use these high-tech investigations to refine our clinical knowledge rather than replace them. Spend time in listening to the patient and examining your patient. 90% of times you will be rewarded with the correct diagnosis without wasting time of yourself and money of the patient. I wish you all to be a doctor good. Thank you for your patient listening.